Well, happy Friday, everyone, and good morning. I want to welcome all of you to our 2022 Garth N. Distinguished Lectureship Award. This really is the highlight of my year, and I'm very excited today to welcome each and every one. My name is Daniel Dawes, and I have the honor of serving as the Executive Director of the Satcher Health Leadership here at Morehouse School of Medicine and as a professor in the Department of Community Health and Preventive Medicine. I'd like to thank each and every one of you for being here today. Please note that we have left the chat function open for you to engage with others, but we will not be taking live questions for this event. It is my pleasure and honor to present today an award that is so meaningful, not only to myself, but to our institute, our founder and former 16th U.S. Surgeon General, Dr. David Satcher, and hopefully to all the trailblazers who battled long before us, helping to pave the way for a more just future. With the COVID-19 pandemic, we know that this has ravaged our communities disproportionately. We have to recognize, though, that some good has emerged from it, and that is that we have reached an inflection point in our country's history. If nothing else, the virus has served to highlight the degree to which our most under-resourced communities have been impacted, all because they stood on an inequitable foundation. As a result, conversations are now being held at the highest levels regarding many issues that were once considered too taboo to ever be acknowledged, much less mentioned at these roundtables. By acknowledging their existence, we're beginning to address and alleviate the true drivers of the systemic inequities found not only within our healthcare system, but in our society at large, that have created political, social, and economic disadvantages, specifically for communities of color. While health equity has gained some momentum, it's important that we continue to keep this topic at the forefront of our agendas so that we can create a brighter and healthier future for everyone. This award is an embodiment of just that, an unstoppable, transformative force for health equity, creating systemic change through heroic action and bravery in their own right. The Garth Graham Distinguished Lectureship seeks to spotlight trailblazers who are leading the creation and advancement of health equity. This lectureship is named in honor of Dr. Garth N. Graham, who during his tenure at the U.S. Department of Health and Human Services yielded incredible influence as the Deputy Assistant Secretary for Minority Health, championing and successfully implementing national strategies, action plans, and policies to advance health equity, including the Affordable Care Act and its 62 health equity focus provisions, which were destined to improve the lives of millions of people living in this country. His courageous actions and dedication toward advancing health equity inspired us to create this lectureship. A trained cardiologist and professor of medicine, Dr. Graham is passionate about the opportunity to improve population health through cross-sector and transdisciplinary collaboration. He is a leading authority on the social determinants of health and health equity, and an elected member of the National Academy of Medicine. As the former Vice President and Chief Community Health Officer for CVS Health, Dr. Graham led the enterprise-wide social determinants of health strategy, working closely with CVS Health's many businesses to ensure differentiated, measurable, and scalable approaches to addressing social determinants of health in communities across the United States. Dr. Graham now serves as the Director and Global Head of Healthcare and Public Health at Google, YouTube, and Google Health, where he is tasked in helping to expand opportunities in technology to support public health and our healthcare system overall. Please join me in welcoming Dr. Garth Graham. Garth, the floor is yours.
Thank you, Daniel. I am so deeply honored by this lecture. And I think just being in the presence of other leaders and folks who have advanced the field of health equity. For me, this lectureship really embodies, as Daniel just said, those trailblazers, those leaders, those individuals who have transformed and impacted the world and have been courageous in their efforts around health equity. Last year, we heard from Dr. David Williams, who has served as a mentor to many of us in terms of his leadership around health disparities, and who has been just an amazing fulcrum for the activities that's been needed to highlight the impact of racism and structural racism on health. This lectureship today, the individual we're going to hear from is equally as accomplished, equally as amazing. And she herself serves an inspiration to me in terms of sometimes understanding the more that we can all do around impacting health and health disparities. You're going to be hearing not just about some of the work that she's done, but you're going to be hearing more as well about her vision around health equity, health disparities in currently and also in the future. But again, as Daniel said, there's so many components of the individuals that have been a part of this, from Dr. Satcher to Daniel, to Dr. Nunez-Smith, to Dr. Williams, who we heard from last year. All of those folks have done so much to advance the field of health disparities, health equity, addressing the political and social determinants of health for our country. And now, as we look to the future, at a time where health disparities, health inequities are not only going to seemingly be persistent, but in some cases even potentially magnified by many of the future challenges we're facing around climate change and other impactful factors. We look to these individuals to continue to inspire the next generation of leaders, those individuals who will take the torch from us and move forward tackling health disparities to a new level. I'm just so deeply honored to be a part of this. And I think one message and takeaway that I've learned from listening to individuals who are leaders in this sphere who've been a part of this overall effort is that we can make a change. Individuals can bring about change to this world in a way that really moves the needle. And I think that's what you're going to hear from in terms of a person whose accomplishments, a person who is passionate, a person whose genuine humility has really worked to advance the field of health disparities. And I think that is really what I think we're here all about, is about this issue around change, impact, and of course, moving the community forward. I'll stop there and I'll turn things back over to Daniel.
All right. Thank you so much, Garth. And of course, you honor us with your presence today. Thank you for those inspiring and, of course, motivational words, and for your outstanding leadership in our movement to advance health equity. Staying true to our vision of spotlighting trailblazers, I'd like to introduce our 2022 recipient of the Garth N. Graham Distinguished Lectureship, Dr. Marcella Nunez-Smith. She's a renowned physician, public health expert, and leader, serving as the former presidential COVID-19 Health Equity Task Force Chair, and was instrumental in mitigating the impact of the COVID-19 pandemic among people of color, people with disabilities, LGBTQ individuals, and people living in geographically vulnerable areas. At Yale University, she currently serves as the Dean for Health Equity Research and the C.N.H. Long Professor of Internal Medicine, Epidemiology, and of Public Health and Management. Try saying that 3 times fast. As the COVID-19 pandemic has shed national attention on the health and healthcare inequities of marginalized populations, she was called upon to serve on the governor's Reopen Connecticut Advisory Group and to chair its community committee. She served as an advisor to the Biden-Harris campaign and subsequently named co-chair of the Biden-Harris Transition COVID-19 Advisory Board, and then served in a pivotal capacity as chair of the COVID-19 Health Equity Task Force in the administration. And while many forget our fellow Americans residing in the U.S. territories, many of whom struggle to reach their full health potential, this was not the case with Dr. Nunez-Smith. She went about immediately securing funding to leverage the Eastern Caribbean Health Outcomes Research Network, ECORN, an organization she established and one that I will discuss in further detail momentarily, to improve the COVID-19 testing cascade in Puerto Rico and the U.S. Virgin Islands. Many of us have read the successes realized through that effort. It is no surprise then that her research focuses on promoting health and healthcare equity for structurally marginalized populations, with an emphasis on centering community engagement, supporting healthcare workforce diversity and development, developing patient-reported measurements of healthcare quality, and identifying regional strategies to reduce the global burden of non-communicable diseases. Dr. Nunes-Smith has extensive expertise in examining the effects of social and structural determinants of health, systemic influences contributing to health disparities, health equity improvement, and community academic partnered scholarship. In addition to her extensive experience in primary data collection, management, and analysis, she has institutional expertise in qualitative and mixed methods, population health, and medical informatics as founding director of the Equity Research and Innovation Center, or ERIC. But her experience in research doesn't stop there. She is the principal investigator of many NIH and foundation funded research projects, including an NIH NCI funded project to develop a tool to assess patient reported experiences of discrimination in healthcare, where she conducted an investigation of the promotion and retention of diversity in academic medical school faculty, and has published numerous articles on the experiences of minority students and faculty. Funded by NIH NIMHD, she established the Eastern Caribbean Health Outcomes Research Network, or ECHORN, a research collaborative across 4 Eastern Caribbean islands, supporting several chronic disease research projects and enhancing health outcomes research and leadership capacity in that very much needed region of the world. She's also PI on one of 5 NIMHD funded transdisciplinary collaborative centers on health disparities, focused on precision medicine, which leverages the ECHORN infrastructure to conduct collaborative research on hypertension and diabetes. It is now with great esteem and admiration that I present our 2022 Garth N. Graham Distinguished Lectureship Award to my dear friend and mentor, Dr. Marcella Nunes-Smith, for her impressive life's work, relentless dedication to improving the quality of life for our most vulnerable populations, and for advancing health equity and health justice overall. Dr. Marcella Nunes-Smith, welcome.
Thank you so much. What an incredible honor. This I am almost speechless, and I know I cannot be because I have a keynote to deliver in a few minutes. But thank you so much for this award with my dear friends, my dear colleagues. If I might,
Yes, yes.
this arrived. This arrived, and it is
Oh,
lovely. I hope everyone can see it. And if I might may read it, the 2022 Garth N. Graham, MD, MPH Distinguished Lectureship presented to Marcella Nunes-Smith, MD, MHS from the Satcher Health Leadership Institute. In all seriousness, this is an incredible honor. I am very grateful and thankful for it, and very grateful and thankful to both of you. I appreciate you deeply for your luminary leadership in health equity.
well, you are very deserving, and thank you again. You honor us by accepting this award. Thank you so much, Dr. Marcella.
Well, thank you so much. One of the most exciting parts of this lectureship is being able to be in conversation with all of you. And I'm going to take maybe 40 to 45 minutes to share some reflections. I think some lessons learned. We're most certainly still on the COVID-19 journey as a country, as we are here in year 3 of this global pandemic. But my thoughts, I think, might be most apt to talk about how we center equity in this process. As Daniel mentioned, and Garth as well, it is imperative for us to recognize this is a moment. There are certainly those conversations that are happening that haven't before. There are certainly, I think, recognition of the deep, extensive scholarship of so many people we've mentioned and others we haven't named, but who have, in fact, been trailblazing in health equity. So we know what to do. But how do we make sure that the moment really does become a movement? And how, as we do that, do we center COVID-19 in policy, in partnership, in our fight for health justice? So during my time today, I really want to talk about that. And as I look back and look forward, maybe share some of the insights and activities from that and some of my deep takeaway lessons. Next slide. Thank you. So, in three parts today for our time, we all have at this point a lot of personal connection with COVID-19 and sadly, loss. But it's important, I think, to context set for us what it really means to witness collectively the disparities that COVID-19 has laid bare, the inequities that have been made very clear. We cannot unsee what we have seen in this pandemic. Then I'll turn to talking about building an action-oriented research portfolio. It has been amazing to work with an ever-expanding team and network of colleagues and research portfolios. And one of the things I think that was really fantastic in COVID-19 was how many collaborations stood up very, very quickly to advance our science and our knowledge and access to all of that in COVID-19. And I just want to share some of the activities that we did here at ERIC during that time. And then I'll end by talking about partnering to drive a national response. That's going to be a theme certainly throughout, is how partnership is at the core, at the center of all health equity work. So first, when we talk about COVID-19 disparities and inequities, next slide, I think back to spring 2020, and now, it's quite notable, right, to be part of conversations and have people use words like health equity who didn't before, to have this in our lexicon, to know that regular folks are beginning to understand disparities and even deeper social inequity. But at the beginning of the pandemic, there really was not a lot of transparency around exactly what were the disparities, what were the inequities, what were we seeing in COVID-19. In addition to hearing me talk about partnerships quite a bit for the next brief period, I'm going to talk a lot about data too, right? And this slide is going to speak to that. I have come to deeply believe and recognize that data is a critical, fundamental, foundational part of our work for health justice. It has been a form of violence, and I deeply believe that just the data invisibility that's come to our awareness. When we have our data sets, our data infrastructures, we are reflecting our values and our choices in what we collect and what we don't collect, and in what we report and in what we don't report. And so I will always come back to that key, critical, necessary element for data. And it's in that spirit that my colleague, who's pictured here, Dr. Carrie Gross, who is faculty here at Yale School of Medicine as well, called and said, what are you seeing and thinking about the reports that we're getting? We should really take a closer look at what's happening in this country with race and ethnicity and COVID-19. Much of the data we were seeing at the beginning really didn't even take into account age adjustment. Now, why is this important? It's important because in this country, people of color, in particular, Black and Brown and Indigenous people, live sicker, die younger than white counterparts. And so we have to take that into account in our statistics, in our calculations, as we look at things like mortality rate. And so Carrie and colleagues at University of Pittsburgh and Tufts, we set out to ask this question around age adjustment in mortality rates. And you'll see here, one of the big takeaways was that we were undercounting and under-reflecting the deep, disparate impact of COVID-19 on people of color with mortality when we looked at age adjustment. But next slide, I think, back to this idea of data and what we collect and what we don't collect. We didn't set in necessarily thinking this was going to be one of our top line findings, but we had to confront the reality that data were incomplete, data were missing. So even when we asked a basic question, a fundamental question, who is dying in our country from COVID-19, who was infected from COVID-19, it was really hard and a patchwork. And the lightest coloring on the screen shows the states that weren't reporting at all on race, ethnicity as a variable. And only 8 states actually had data that we deemed of sufficient quality to really comment and report on race, ethnicity. I'm proud that Connecticut, where I live and work, was one of those states, but it really set forth the work that we knew we had to do ahead. Next slide. One of the questions and conversations, certainly as I talked to people coming out of that report, and we were certainly one of several teams that were highlighting the need to think about data, but of course was root cause. And in so many settings and so many conversations, people said, well, why do we see these differences? What is the biology to explain this? And I'm very pleased and very proud that we've had sort of a national awareness and a national education. I don't have those conversations anymore. People now, I think, truly understand the social, the structural drivers. We know that race is not a biological concept or construct, but we know that particularly in our society, it does have meaning and it does have influence and impact, and largely through what we've been talking about, what have been systematic, and intentional disinvestments in many poor communities and many communities of color over generations. And so it's this multifactorial. This list is not even fully comprehensive, but it is multifactorial how we've gotten here. It is a roadmap for us for how we move forward. Next slide. So I want to turn now to talk about the work that we did at ERIC, with this in the background, with our understanding that what we needed to look at and interrogate was really this confluence, how COVID-19 was taking advantage of the tracks that had already been laid across multiple systems. Of course, I'm a practicing physician. I work in healthcare and think a lot about health, but understand how important it is to also talk about the legal system, to talk about our educational systems, to talk about economic opportunities, where they exist and where they don't. And so bringing all of that knowledge to bear to inform our research is something we aim to do here at ERIC, and to do that in a truly community-partnered way. Next slide. With all due credit to my colleagues here at ERIC, this rapid response posture, I really am quite impressed by how quickly the team stopped. And this happened across lots of teams on lots of types of science and research and activity. But teams sort of stopped what they were doing and focused their energies on contributing to our scientific knowledge base for COVID-19. So here at ERIC, we stood up 2 research pods, really thinking a lot about, in particular, healthcare and what we could be doing differently in our care delivery settings to improve outcomes for those affected by COVID-19. Next slide. I put this up here as sort of a testimony to what can happen quickly. This initiative and these activities brought together over 50 people who were not previously affiliated with our research work at ERIC at all, from Yale and beyond, but all walks: senior investigators, junior investigators, trainees, staff, others who had never done research before, but who said, we think we can be of help and can contribute to this mission and this work. And if there are some lessons, some pearls to take from COVID-19, this ability, right, this is a small example of it, but an ability for us to take down some of the silos, and we've seen this happen across private-public partnerships as one example, but to do that quickly and urgently in service of a national need and a national crisis. And so in this way, this is part of our story here at ERIC too. Next slide. So just to lift up a few of the projects, I'll walk through a couple of them very quickly, but work that I think has been difference making. So these are 2 of the papers that were published that really highlighted what many were starting to observe, that the protocols we were using to triage patients to limited resources for COVID-19 were in fact perpetuating and worsening disparities and bias in care and care outcomes. And so putting this out there, prompting and changing clinical care practice here in our own institution, but across institutions in the country, very important. Next slide. In the very kind intro from Daniel, we talked some of the work that we do in the Eastern Caribbean through the Eastern Caribbean Health Outcomes Research Network that is focused on chronic disease. NIH very quickly, again in a rapid response way, stood up several initiatives to be sure that communities were not getting left behind as we made advances in scientific discovery, particularly in this example around the RADx UP initiative around testing and testing technologies. So we worked closely with our clinical colleagues in the territories of the U.S. Virgin Islands and Puerto Rico to be able to make sure folks could be connected with the latest and best in testing for COVID-19. Next slide. Very early on, too, in the arc of the pandemic, our colleagues reached out to us from the African American Research Collaborative, as well as colleagues of the National NAACP. So we need some work, some research that's rigorous, that can elevate the voice and perspectives of African Americans. And we conducted one of the first national polls of those identifying as Black and African American in the country to understand really COVID-19 perspectives and influences. I think a few things to note from that work, I think that maybe weren't clearly understood. We found that those who responded were working very hard to adhere to public health recommendations and guidance at the time. But we're really quite worried, and turned out to be understandably so, about what it might mean to adhere to things like masking guidelines and how that might put their own safety at risk in terms of interactions with law enforcement, for example. We also saw that there was a substantial degree of anticipatory discrimination. People worried quite a bit that they would not be treated the same or have the same access to COVID-19 resources as others. And the data bore this to be true in the end. We did follow up this work with an extended partner network in a vaccination poll sometime later. And I think continuing to keep the center on the voices, the lived experiences of those in the communities that are most affected are critical. And this type of regular inquiry through poll or other methods is critical, and certainly was critical to the work that we did in the federal administration and in many local administrations. And so we'll always lift up the value of this kind of research. Next slide. As was mentioned before, it was an incredible honor for me to work with Governor Lamont here in the state of Connecticut in the Reopen Connecticut Advisory Committee, and to chair our community committee that was charged with making sure that we were protecting those populations most at risk for illness or death. And I will say Connecticut was one of very few states where we had an established committee as part of that reopen work, looking at these questions and in partnership. And here listed are the amazing and multi-sectoral individuals, advocates, experts, champions from within and outside of government who came together for this work. Next. And so how does the research piece tie back into this? You know, early on up top, I talked about how Carrie Gross and I and colleagues really set forth to say it's important how we talk about these data and how we show and visualize these data, that age adjustment makes a difference. Looking at the burden by those age strata and categories tells a more complete story. So here in Connecticut, through the reopen work, we quickly, and the government quickly updated their data dashboard to present the data we were seeing in terms of mortality and burden, age adjusted. And this happened as well across the country and at the CDC. Next slide. Also, as part of Reopen, in the community committee, we paid a lot of attention to what the barriers were to people being able to adhere to the public health guidelines and recommendations that were being issued. And, you know, we had a stay home and stay safe campaign. And of course, we now fully understand that for many people, there was really never an on-ramp to that. All those that whose work we deemed essential in that time, and perhaps were slow to provide tailored and targeted public health advice to. But there were many who wanted to adhere to these recommendations, but really had unmet basic needs that stood in the way of doing that. And so as part of this committee, we stood up a rigorous process to support people in their quarantine and isolation by providing those basic needs. And at ERIC, we were, through a philanthropic donation, able to study in real time and evaluate that process and that support, which had already reached over 7,000 people in Connecticut to allow them to more safely quarantine and isolate. And through that work, we're able to extend that program as we briefed senior officials in the administration. So this is a moment for me to pause too as we talk about research, as we talk about the partnerships, to lift up philanthropy as well, that has played an incredible role in our response to COVID-19 at local, regional, and state levels. And one example here in terms of funding that real rapid response work that is often needed for us to ensure we're making the right policy investments in real time. Next. I'm very privileged to continue our thread and conversation about all the partners that have to come to the table and philanthropy to be part of the Community Foundation for Greater New Haven as a member of the board there. That is a regional organization here in Connecticut. And the work that we did through that organization, again, in a rapid response way to respond to COVID-19 in our communities, but to respond again in a way that honors the truth regarding why we got here and the structural racism and realities and biases and discrimination that, that really have worked almost in cahoots to create the predictable impact of who was harmed first and harmed worst by COVID-19. Next slide. So with the remaining time and probably the most time, want to talk about the partnership and the work to drive a national response. I mean, so far we've had a chance to discuss the importance of data in our conversations about health equity and in particular COVID-19 equity, where there were gaps, what is incomplete, what's often missing, the reality that what is incomplete and missing often reflects our values. So many people invisible could not see themselves at all in the COVID-19 data. An example, thinking about our delay in understanding the exact toll in indigenous communities, the toll in carceral settings, for example. Turning to think about how those kinds of challenges present opportunities for us in a research environment as one, and how importantly to get the research done that we need to, it does take multiple investments and funders from philanthropy, certainly from well-established funders such as the NIH and others, but it also takes a willingness of people to step up, perhaps to go into new and different directions from their own research or from their own prior experience, but to bring their contributions from wherever they are, and for us to recognize and honor that expertise as we build research teams that really reflect and represent the perspectives across all of our neighbors and communities. So with those two vignettes in our rearview mirror, to turn now to how that all also informed what I brought and tried to contribute to our national conversation on COVID-19. Next. And so a little bit of the chronology here, and just to start off thinking about the campaign and the transition, and I think it's important to go back to that, to sort of remind people where we were, that we didn't at that time have a national strategy to address or combat COVID-19. And we also were dealing with extremely limited resources in all areas, be it PPE, so the protective equipment such as masks and respirators, to testing and testing availability, to therapies that were new and emerging but in limited supply, and of course, vaccines. Next. So this is a snapshot from August 2020, which in many ways feels like a long time ago while feeling also like yesterday. And I think it's important, pictured here along with colleagues, now Surgeon General Murthy, Dr. Kessler, Dr. Nicole Lurie, all people with deep experience to bring to bear in our current situation. But importantly, having at that point candidates that were clear, crystal clear, in the importance of centering equity in our national response to COVID-19. And because of that clarity and that unwavering focus, I was very privileged to be invited to be part of a team to advise on how we might operationalize such an ambitious but necessary goal. Next. So moving ahead from the campaign, again, this idea of urgency, I think that is with us. It's always with us in our quest for health justice. It was certainly with us as a nation in understanding how we might recover and get to a new normal with COVID-19. Privileged to co-chair with the already aforementioned Drs. Murthy and Kessler, our Transition Advisory Board. Next, which brought together extraordinary leaders from around the country to bring their scientific expertise to bear on our process and working very hard, but working with the policy teams who are part of the transition, who are working tirelessly around the clock to stand up our first national strategy to address COVID-19. Next. You know, I always want to take a moment here to stop and talk about this as someone who, I'm a practicing physician and a researcher here at Yale, and I have to admit that perhaps I did not fully recognize just the enormous sacrifice and work of those in public service on our behalf. And this is one example in a very short timeline, very small but mighty teams working to stand up and get in place our first national strategy. There are 7 goals, and really importantly, I want to call out the first around trust and our recognition with where we are as a country, and trust, and where we are when we talk about health equity, in trust and trustworthiness being at the forefront. But every single one of the goals in the national strategy centered on equity. And so we lift up goal 6 here, which was around protecting those most at risk and advancing equity, including across racial, ethnic, and geographic, rural, urban lines. But importantly, every single one of these goals was interrogated around equity. Next. These are the components of that national strategy, goal 6. I think it's important for context setting because in a new administration, these particular focus areas, part of this national strategy was really the roadmap for work. And I would, not to read each one, but I would say what is very important is that some anchored in the moment when we think about establishing something like the COVID-19 Health Equity Task Force, connecting people with the resources necessary to preserve life in COVID-19, but recognizing too that there's forward looking, back to our understanding of that multifactorial sort of honeycomb of why we're here. We know that we have to work on things like ensuring consistent access to high quality care. So now work and future work embedded in that national strategy, but cutting across everything: partnership, outreach, engagement, and really living into these values. These are not just words, they are not phrases, they are not talking points, they are ways of being, ways of showing up, ways of being responsible and accountable for the work that we're doing. And this was a whole of government philosophical approach to the response. Next. And so with the remaining time, I'm going to talk some about the work with the White House COVID-19 response team, and then close by talking about the historic presidential COVID-19 Health Equity Task Force. Next, so it was a privilege to serve as a senior advisor to the White House COVID-19 response team and to HHS in this work. Pictured here are just a few of the extraordinary colleagues with whom I was able to work closely daily in getting our country vaccinated eventually, but at first well protected through access to PPE and testing and therapeutics, and also to accurate information, which, looking back now, I would say we all likely estimated just what a worthy adversary and opponent we would find in misinformation and disinformation about COVID-19 and COVID-19 vaccines and treatment moving forward. In the bottom right corner, to acknowledge working right alongside Jeff Sines as our nation's first COVID-19 coordinator, who was a wonderful lead and shepherded all of the many members, but the whole of government in that federal response for COVID-19. Next. And I refer to these colleagues often as my COVID-19 response team, health equity family within the team, Dr. Cameron Webb as a senior policy advisor for COVID-19 health equity, and Osar Rahman as our junior policy analyst, working embedded within the White House COVID-19 response team on health equity. Next. I want to do a quick just overview of some of the efforts to advance COVID-19 equity that the president took decisively early on. And on this slide, this is about ensuring that people have access, and people who are often forgotten and made invisible, are unseen. But distributing free masks, free testing through channels like community health centers and food pantries and others, making sure that there is access to therapies as they emerge. Here, lifting up monoclonal antibodies, but one of many, and ensuring that. Next slide. And maybe this is a moment to stop, because certainly we knew from the beginning, from the campaign, from the transition, and I'll hover here for a minute, because we knew that vaccination was going to be difficult, right? Vaccinating an entire nation was going to be unprecedented in challenge scope, but certainly doing that in an equitable manner and getting that vaccination to everybody we knew would be a challenge. And so I'm going to walk through some of the strategies that I think contributed to us getting here. But what is here? And let's look at this. In September 2021, this nation closed the racial equity gap in vaccination for adults. This is something that we all knew had to be done, but no one was sure could be done. On the best days, there were 10 points of difference between racial and ethnic groups, between whites and others in this country for vaccination uptake. And when we saw in September 2021 many data sources, and again, the value of data sources that are coming from multiple sectors, and we saw many, many data sources all triangulating on this reality and this new truth that as a country we had achieved vaccination parity, that achievement most certainly in partnership. Progress to note, of course, so much work to do, but to everyone really in earshot, this was all we work. We know so many people worked to get us here, but we had to get here, and we did. And now to see recent reports in Washington Post, New York Times, and others showing what are the intended positive sequelae of getting vaccination to everyone in terms of decreased morbidity and mortality from COVID-19. So really important work. Next slide. I'm going to take a few minutes just to talk about some of the areas of emphasis in the federal administration that really had that North Star always from the beginning. The president held that North Star always from the beginning. Our work was really to get to that vaccination parity for adults in our country. So very early on, the president prioritized access to vaccination by standing up numerous direct federal vaccination channels. So by way of reminder, the majority of vaccination doses that were, of course, purchased by the federal government went directly to states and local jurisdictions, tribes and territories for distribution. And so, but some were held back intentionally to stand up and support these direct federal vaccination channels. And so what do I mean when I say that? Standing up those community vaccination centers that were run by FEMA, but some large and some smaller in size, but across the country to make sure people got connected with vaccination. Sending vaccines directly to federally qualified health centers, to rural clinics, to lookalikes as well, to make sure there's access across geography. Sending vaccine to our hemodialysis centers, where we know patients of color are overrepresented as hemodialysis patients, as one example. And then working with our retail federal pharmacy program and partners to ensure that a significant proportion of retail pharmacies that would be carrying and distributing the vaccination would be in high need areas. And really in a data-guided and data-driven approach, using the CDC's own social vulnerability index to think about where we locate vaccination venues through these federal programs. So prioritizing access, the president knew was step one. Next. But that was step one. And so moving forward, making sure necessary but insufficient that vaccination venues were in places that were trusted and trustworthy, that were accessible. But hearing every week through roundtables that I was honored to host in the White House, to listen and learn from constituents, many people boots on the ground, what's happening, what are the barriers. We always said, we're here to set an action agenda, not to hear what's going well, but what isn't, where there are those opportunities to do better and do differently. And we heard consistently, and the president responded to those structural barriers. People could not get time off of work, for example, for vaccination and recovery, so providing tax credits for that. Many private industry partners stood up so that there would be transportation, childcare provided right alongside the initiatives. And of course, making the process easier every step of the way for people to be able to get vaccinated. Next. And really important, so step one, prioritizing access. Step two, addressing and resolving structural barriers. But increasing vaccine confidence really is fundamental. And perhaps of all the areas of work and activity, this is the one where partnerships the most critical. And so certainly within the federal administration, standing up a national public education campaign, putting resources there, working with those trusted messengers across the country, across communities, at the core of it. But maybe not even anticipating just how different that vaccine journey would look for so many people, and how many were trying to navigate so many inputs and not knowing where and who they could trust to get good information. Next slide. This is, I think, a moment to acknowledge with gratitude and thanks all the many partners in this work, including the COVID-19 Community Corps that stood up, bringing together over 8,000 members. These are the trusted messengers who came to be sure that they were getting the best information from HHS, from the CDC and others, that they could then share within their communities. Next. But also really acknowledging those outside of government who stepped up to play pivotal roles and contribute. The conversation, which was an initiative with YouTube and KFF and the Black Coalition Against COVID, but really bringing to people information that was accurate, that was trusted, that was delivered by trustworthy messengers in a consistent, accessible way. All of this important in getting us ultimately to vaccination parity. Next. And I'll close it with a few minutes on the Health Equity Task Force, because this work really marches in parallel. And it was the very first day in office for the new administration, next slide, that the president signed into being this first of its kind group. So a presidential health equity task force focused on COVID-19 with a charge really to provide recommendations on how to mitigate the disparities. We were living in real time, but looking ahead, knowing there will be future pandemics, and how do we prepare ourselves so that it's not so predictable always this pattern of who is harmed in these times. Next. Next slide, please. And so to nod too, I had a moment earlier to salute my colleagues on the Connecticut Reopen Committee, and here I take a chance, an opportunity to salute my colleagues in the Health Equity Task Force. The president invited 12 people from across the country, all with demonstrated expertise, lived experience, situated wisdom, and fierce advocacy in their communities and in their spheres of influence, who we all knew would not be shy in coming to this table and voicing truth and what we needed to be doing differently as a country to achieve health equity. Next slide. And also, I think very importantly, the Health Equity Task Force, by design, similarly to the work that we did here in the state, inviting those from within the administration who are senior leaders across many agencies, many departments, where we knew the levers would exist to be pulled. So whether it's education or agriculture or justice, our colleagues coming together to say, we can work as one committee to identify where there are opportunities for policy progress. Next slide. We had an incredible team supporting us of career federal officials. Our executive director, Dr. Martha Okafor, here shepherding us through that. By design, we had a quick sprint pace of having monthly public-facing meetings, choosing topics to drill down on, with so much appreciation to Daniel Dawes for being one of our speakers at the first meeting publicly of this task force, but really incorporating, as he did and so many others, subject matter expertise through this work. And so what's not pictured here are the hundreds of hours the committee members put in between meetings to get us to interim recommendations that were shared at each one of these. Next slide. So I do invite everyone to look at our recommendations. The task force submitted to the president through the COVID-19 coordinator the final report in October of 2021. And with Dr. Okafor's very accurate guidance, we also submitted an implementation framework and an accountability plan. And these are all publicly facing documents that we hope will be of use, not just to the federal administration or to local governments, but to everyone who's on this march for health justice. So of the many recommendations, there were over 300 in total and 55 that were prioritized. There were several top lines that I think reflect the values we've already been discussing today. The importance of having community-led solutions. So not just a seat at the table, but leading and steering and making sure that the resources go there. Communities are always the experts in what's needed for health equity, to thrive, for well-being, and we should put ourselves in a position of service to that knowledge. Absolutely and fundamentally, building a data ecosystem that really is going to make sure that we are tracking and following and are accountable as we talk about the metrics for health equity. Understanding and knowing that we need shared language, shared frameworks to drive our work, that we need a health workforce that's going to be reflective and representative, that we make sure people have access to high quality care, but that we also think about our public health workforce, our healthcare providers, and our community-based workers. And that we cannot take our eye off of this, right? Even as attention turns other places, that we always have to make sure that there are entities and bodies that are holding this work, steering this work, shepherding this work to success. Next. Next slide, please. Next slide, please. So as I wrap, there just aren't enough thanks, really, to all of the many people who stepped forward, who made great sacrifice. Pictured here are just a small fraction of the organizations we were able to work with in great partnership through the task force, through the work in the whole of government response to really make a difference. But what I'm most grateful for is that all of these groups and many others spoke truth, right? And it's critical for all who are leading organizations to know creating open, closed opportunities, but signaling that it's important we stand ready always to respond to the learnings that people bravely and courageously share. Next. And so this was work that carries through, and I'm very, very grateful to Senior Advisor Cherise Perry, who was at HHS and worked right alongside with me throughout this entire journey to be sure that we were always centering and anchoring on the groups, the voices, who are most affected by COVID-19. Next. So at the time this report was submitted, we were really pleased and encouraged as a task force to know that the vast majority of recommendations were already in progress or had been completed. Of course, there are some recommendations that require beyond executive action, but knowing that resources were being directed where they needed to go. One example here of such an announcement. Next slide. And really critically, coming back to where we started, a key takeaway, because this is important as the policies that were enacted, as getting to a place of vaccine parity for adults in this country, was getting to a place of improved data and data quality and collection. And right from the top of the administration, making this a key, that deep understanding that we need data to be able to track, to direct limited resources, to hold ourselves accountable. And there's been incredible progress on data completeness. Next. Next slide, please. But we have to keep our eye on this. And so continuing, I was able to work with the Satcher Health Leadership Institute, the Black Coalition against COVID, to release the State of Black America and COVID-19, a 2-year assessment earlier this year, where we talked about where there's work still to be done around long COVID, around educational losses and gaps, around access to high quality healthcare and economic opportunity. So we still, at the moment where we note the work that has been done, recognize and commit to the work ahead as well. Next slide. Next slide. So let me close with thanks for this opportunity to share these thoughts, these reflections, to say that we know the work is long, but it is urgent. But we perhaps are in a place we haven't been before with this collective and shared understanding and witnessing. It's going to take absolutely every sector to understand, to step up, and we've seen this in COVID-19, to know that there is a role to be played. And it really is one best executed through partnership. But to use the tools that we have and maybe to imagine anew where there are opportunities. And it is all of us. It is we work. So each one of us, big, small, are difference makers, are change agents on this journey for health justice. And I am ever optimistic that we will be successful. Next slide. So in closing, I want to thank the extraordinary teams that I have the opportunity to work with. This is the ERIC team here for all that they have done throughout the COVID-19 journey to support the work I've been fortunate to be a part of. This has been a pleasure, and I thank you for this time.
Well, thank you for allowing us the privilege of being your students today. Marcel, I've gotten several text messages from folks who said, she's awesome. I want to take a class with her one day. So thank you for allowing us into your classroom today. And again, thank you for helping us to think about how we can actualize this really difficult concept of health equity, how you've done it so successfully, how we might be able to employ it, whether in research or in practice, or whether it is upstream as we try to tackle the upstream determinants of health. So again, I think through your efforts and collectively with all of us, right, we'll be able to create a more healthy and equitable and inclusive tomorrow.
Yes.
So
Amen.
What a privilege. And again, thank you. So at this time, I'd like to welcome back Dr. Garth Graham for our 25-minute moderation session. It's our Q&A session. So Dr. Garth Graham, thank you for joining us back. So Dr. Nunez-Smith and Dr. Graham will have a moderated Q&A session with some pre-selected questions from our medical justice and advocacy fellows and our diverse executives leading in public health fellows. Again, thanks to all of our fellows for submitting those questions. We really appreciate it. So Dr. Graham, Garth, the floor is yours. Please.
Thank you, Daniel. And I do have a number of questions here, Marcel. I will say one thing. Daniel mentioned text messages. I did get one interesting text message I thought I'd read to you. Because sometimes you do this work like you have done and people don't know. It's a very simple fact that it's carrying a heavy burden, a heavy weight, and to accomplish what you've done. And sometimes just getting the word out is important because it inspires other people. So a text message I got from someone said, I had no idea. I can't believe they did all of this. That just really makes me inspired. So I think it's just interesting to know that being able to articulate what was done, especially around closing the gap, which is an actual discrete goal that we have been challenged with for so long in public health, is amazing. Anyway, I have a bunch of questions here from the fellows and the scholars that I should get to. Try and work in one of my questions towards the end. You can tell what my question is going to be, Marcella. It's going to be about balance and how do you, because especially for the fellows, it's going to be about how do you achieve balance. But I want to save that for the last. Okay. First question is from DEL-PH scholar Andrea Lowe, MPH. And Andrea asks, should public health and healthcare be reframed as a result of COVID-19? So let me repeat that again. Should public health and healthcare be reframed as a result of COVID-19? If it should be reframed, what does it need to look like? And what are your recommendations for getting there?
Yeah, thank you. I really appreciate that question. It's a very thoughtful question. And I have to say it's one that I do spend time sitting with, right? Versions of this question. So what do we do now with this knowledge? I mean, we speak so often of how under-resourced, underinvested our public health infrastructure is, and how that was abundantly clear, right? So, as I think about all of those folks working tirelessly, spending time with local public health officials brought that home more acutely than anything else, right? I mean, these were folks who are extraordinarily talented, extraordinarily committed, often working with just such limited resource. And then we call upon and see the need for public health leadership in these moments of crisis, and perhaps are able to find ways for temporary solution. But what is our long-term planning and strategy to really undergird and support our public health infrastructure? I think the fundamental to the question, I think the answer is yes. We have to be doing differently moving forward. There has to be a reimagining. One of the questions I ponder a lot, I mean, Daniel and you both have talked about and are experts in the social drivers, in the political and structural determinants of health. Many people can now articulate them, right? Can now talk about and understand even that connection between something like stable housing and health, something like access to nutritious food and health. But how do we begin to think about, what is a health dollar? What is a healthcare dollar? How do we link our knowledge now to our practice, to addressing? These are really prevention strategies when we think about addressing SDOH, or the social determinants of health. And how do we do that? And how do we deepen those partnerships between public health entities and healthcare systems? And there's a lot of interesting, I think, natural experimentation. But as we talk about the next generation and the leadership there, and I'm inspired by the next generation, I think this is an area where you will lead, fellows and others, is how do we have very difficult, hard conversations questions about things like resources and fund flow, but also leverage innovation to create spaces for shared interests, shared mission, shared goals between clinical care delivery enterprises and public health agencies. And let me also add community leaders and community voices at that co-design table.
Excellent. Very major point you made there, Marcella, about what the next generation and what these next generation of scholars and leaders have in front of them as well. So, next question from DELPH scholar Alexis Carpentier. Alexis asks, when ensuring an organization follows its mission and change is necessary, how do you navigate organizational change to improve efficiency?
Yes. Good. Thank you. I love it. The fellows are bringing the A game questions, right? These are the right ones because there is a lot, and it's maybe not it's not theoretical. Let me just say that that's not a theoretical question. There are a lot of organizations that are responsible, that are stepping up and trying to do that work of interrogation, right? Looking within, looking at the structures, the policies, the systems, collecting data maybe that they haven't before, trying to think about how to be responsive. So there are a lot. We want to bring more along, of course, but that is a question I get asked in a very practical, pragmatic way from a lot of organizational leaders, right? How do we manage and steer this change? So that question in and of itself, I say, is the right track, because those who think that this work can be done without attention and intention around organizational change will find that it will not be successful, right? These initiatives will not flourish. So this kind of attention up front to the work of organizational change, I'm ever grateful, have worked very closely with several experts in organizational change culture. Right here at Yale, we have several, and many of them, quite frankly, were providing their expertise to us in the work we were doing in the federal administration, right? Think about this and the organizational change implications. So as an individual, it is worth your investment to build your own toolbox and toolkit in organizational change management and leadership, but also understand that there are many colleagues out there. You can see I'm a big tent person, so I'm always excited to call a friend. But make sure as people are doing these kinds of big change movements, we've at least called a friend to help us think about that organizational change piece.
Fair enough. I love that. I love that calling a friend. Okay, a couple more questions. Um, Another question from one of the fellows. What is the role of data or the lack thereof in addressing health equity? How did this impact your work as a part of Governor Lamont's advisory group, Reopen Connecticut, and as chair of the White House COVID-19 Health Equity Task Force? So the question is really what do you think is the role of data?
Yes. Thank you for that question. This is my number one favorite topic, right? Is the role of data. And I had a colleague who actually said, think about the time goes so quickly. You cannot achieve, you cannot achieve all the things. And so what is one area that you think it is a must-have to address and change? And my answer, it's data. It's our data area. It's what we collect. It's what we report. I had a chance, some in the keynote, to talk about data. Some of those early understandings, just the recognition, when we even variables as maybe simple as race, ethnicity not being collected in a comprehensive way. That data invisibility challenge that we have. I remember early on asking for a report on people with disabilities and COVID-19, and not that those aren't data that exist, right? And so this cataloging, it's really important. And the president on the first day with the federal administration signed several executive orders related to equity, including creating an intergovernmental committee task force to look at data and this question of data and data equity, and really make recommendations about changes, and changes are underway. So there's a lot of progress made. most certainly the president and vice president working really hard alongside the teams at the CDC and others to get local jurisdictions to report on data as an expectation. I mean, I think this new norm setting that we are going to have conversations about data, we are going to have shared data standards and high data expectations, that we will not then admire the data or admire the problems that the data might reveal, but then we'll use it to guide and target our interventions. Often we are talking about limited resources. That was very difficult as someone asked by leaders, right? Where should I be sending our limited resources? To not always have that data to guide those responses, that is unacceptable moving forward. So if somebody asks me, what are the three most important things that we need in our health equity work and in crisis? Number one is data, number two is data, and number three is data.
Well said. Well said. Next question. What key health equity mitigation strategies from the COVID-19 pandemic can be implemented for the monkeypox outbreak and any future outbreaks and pandemics?
Yeah, so here it's that also, right? These spot on questions, because COVID-19, we can think about it in a vacuum. I was actually delivering a lecture yesterday, and the question was really almost an opportunity cost question. We've shifted a lot, focused a lot on COVID-19. What does that do to so many of the other things that we know have been affecting our communities all along, right? And whether that is pandemic or infectious disease, as mentioned, or it is chronic disease. So often we heard reference to the syndemic of people trying to make their way through battling uphill often against some of these structural realities in their lives, and then on it we layer these other acute health concerns. So I think there's a lot we can learn. I will say that to start, which is in the work of the task force, in the work of the response team, the idea all along was around being able to have these roadmaps ready to go moving forward. So whether it's about the positioning of resources, I've heard you, in fact, say this many times, Dr. Graham, the relationship investment and sustaining the relation, that doesn't come, right? You don't call someone and say, hello, let me introduce myself. Can we work together now on X issue, right? That is not the time to make relationships. Relationships have to be nurtured and sustained over time. And I think that is probably one of those key strategies I don't want us to lose sight of. I think there are many that people are dropping that ball on, but understanding that many of these grassroots coalitions, organizations, and others, right, being in relationship and partnership in a structural way, in an instrumental way over time is important. But we will continue to face this in terms of pandemics and perhaps our limited readiness. But we have in the task force report and certainly in the whole of government response a way to get ahead of this sooner with the appropriate resources moving forward.
Thank you. Thank you for that. Marcelo, you've talked about the Eastern Caribbean Health Outcomes Research Network in your presentation, and many of us have seen the impact of that. But this question is more about a little bit around history. I got to tell you, I have always wanted to know this too, because being of Caribbean descent, I think many of us have always wanted to figure out how do we kind of blend our professional and all our passions together, which is going to be, again, my last two questions for you about balance and passions. But can you tell us a little bit about how it started, what it means to you both personally and professionally, and its impact throughout the region?
Yes, thank you. I appreciate that. So I'm originally from the U.S. Virgin Islands. I grew up in St. Thomas, a beautiful place. I consider myself ever blessed, right, to call that home. It's sort of the understanding of a child that matured over time. But, it is personal for me, the reality that, the Virgin Islands and in fact, across the territories, we face health professional shortage areas, but also other policy realities that affect health and access to health and And as Daniel said, barriers to achieving full health potential in those locations. And so I've long had an interest in territorial health. The territories themselves very rich in terms of even just geographic location, but also in culture and in people, but treated as a policy collective, often in federal policy, and that is for another lectureship at another time. But I was really quite aware of this and eager to bring a research lens to this question, and with some colleagues here at Yale, we worked with CMS data to look at quality of care in the U.S. territories and found substantial differences, particularly when you think about some of the most common reasons for admission: heart attack, pneumonia, heart failure, for example. And that was highly motivating, right, to understand what do we do there. And to this idea of partnership, right, I was able to reach out and talk to people in the region, understanding because of the cultural vibrance and difference that we should not continue to treat the territories as a monolith moving forward, but thought specifically about the U.S. Virgin Islands and Puerto Rico within a Caribbean context. And beginning this work with ECHORN, reached out to leaders and said, let's talk about these healthcare data we found. And really, early on, got that feedback. We have to take some steps back. We have to do work around surveillance and understanding what's happening here. We face so many natural disasters, hurricanes and others, and we don't even know how many patients we might have to find emergency dialysis for. How can the work of ECHORN be in service of what our policy needs are? And it shifted our entire reorientation. I mean, that's how we orient now, is about our partners. ECHORN is not a research project. ECHORN is a network. It is a partnership and a consortium. And we support research projects, including an intergenerational cohort following over 3,000 community dwelling adults and their biorelated children in the Virgin Islands, Puerto Rico, Trinidad, and Barbados. But it's a partnership. It's a network. And we're really there to create an action-oriented research portfolio that those leaders in government and in the civil sector can use to make change in practice and policy.
This is another question. How do you continue your advocacy for health justice given the emotional burden of the work? That's a deep one.
That's a good one, right? Because I'm not sure the origin of that question, but I thank you for it, because I was at an event this week, and someone sort of said, and this is a physician who is doing a lot, right? And the question sort of became, what can I do? What can I do? And I said, you could rest. You could rest, right? You could rest. And it is an emotional toll. And this is an important thing to acknowledge, right? Because it is the soul. When we talk about COVID-19, every time I'm like, these data, when I say data, and I know today I talked a lot about the quantitative data, but it is narrative. It is the story. And as important as it is for us to track the right numbers and rates, it is understanding the devastation in a family, in a neighborhood, in a community with that loss. What we all miss, right, with that unrealized potential of those many lives that we have lost in COVID-19. It is talking to the family. It is talking to people who are dealing with long COVID. It is all of that is emotional. If we are to be sincere and successful in this work, we must be emotionally involved, right? For so many of us, this is personal, and the work is personal, but we must also be emotionally protective. So that is the right question. And understand, like I said, it has been hundreds of years of very intentional and systematic policy decisions, redlining, others, right, that have gotten us to where we are today. So none of us should expect to carry this burden, right? We already acknowledge that we are standing even now on the shoulders of giants within the field of health equity, and understanding that it's each of us is going to make our contributions, but we must pace ourselves, right, to be of great success. So that unplug, that disconnect, that finding of joy, right? Because the same way I find so many positive stories and people who are like, here in my corner of the world, I have been transformative in this way, and taking from those stories inspiration and motivation and joy. We have to do it.
Marcella, last question. Tell the scholars, the health disparity leaders, myself, all other folks, how you balance, how do you achieve balance as you've been able to do so much?
Oh goodness, I have no expertise in this area. Perhaps what I would say, it's so important. I think you and I, let's we were trained in a culture that said we will reward, right, the tire the pursuit at all cost, right, the not perhaps breaking for rest always, the not focus on well-being, where I was in conversation with the Surgeon General at a grand rounds, and he said, where it was strong work always meant basically working through extreme exhaustion and other things. And so that we need to really reconstruct strong work for the next generation. And that, I think, is our greatest obligation. A colleague texted me this earlier and said, we must role model for the young generations this balance. This is our responsibility, right along with all the content. And I couldn't agree more. I mean, I might give this, and I can't attribute it properly, and I'll be quick, but I don't even give myself the burden and stress of attaining balance, because even that then becomes stressful. But what I will say is that I use this metaphor, right, that I've heard of kind of the juggling of the balls, and understanding that some of the balls are crystal and some are rubber. And it's an exercise I do every morning, right? What are my crystal balls today? And what are my rubber balls today? There are some things that could drop and will bounce back, and there'll be other opportunities. And there are some things where this is the only moment for that. And it changes, right? Sometimes the crystal ball is about my family, and sometimes it's about work and professional opportunities that are there. But that is what I use to guide me. This sort of day-to-day inventory of kind of what's on the plate and what's on the most important and what there is crystal. And I always say, those we keep around, nurture those relationships. Those people are going to keep us real. My family keeps me is very real, keeps it very honest and very humble. You need people around you to set those expectations for your presence and your engagement, and that you're keeping those personal commitments as well, but also the commitments to yourself for rest and wellness and well-being. This is the last. You are all champions here. You are all difference makers here. The work, though, only happens if you are here, right? So take care of yourselves and take care of one another.
So well said. Dr. Marcella Nunes-Smith, above all, in terms of just not what you've accomplished as a professional, the thing I've always most admired about you is your authenticity and your humility. And you've just so happened to change the world while doing that, which is always an amazing thing. Thank you so much. I think, as expected, this lecture was just amazing, and just for me personally, it inspired me to just continue to do more. And I'm sure for all the folks who've been sending all of us messages about how wonderful this is. Thank you so much.
Thank you. Be well.
We're going to bring back Daniel, I think, as we move forward.
Fantastic. And I too ditto everything that you said, Garth. Thank you once again to both of you, Dr. Graham, Dr. Nunes-Smith, for such a wonderful and inspirational discussion. I hope that everyone listening today was able to at least capture one thing, and that is that the pursuit to an equitable America is a marathon and not a sprint. We have only begun to cross the starting line. And as we look and see the Olympic hurdles, we must not lose focus of what lies behind the finish line. It will take continued and massive efforts, collaboration, synergies, novel approaches, the continued unveiling of the narrative through data, the changing of laws and policies, and many more difficult yet surmountable feats, as we heard from our honoree today. Which is why this award will continue to be presented yearly, to continue to encapsulate and embody the works and efforts of health equity champions, both domestically and abroad, who choose to run this race and knock down one hurdle at a time. The Garth N. Graham Distinguished Lectureship recipient will have shown innovative thinking, demonstrating novel approaches to addressing the social and political determinants of health, and creating systemic change at the intersection of policy and equity. Their tenacity to transform norms that have continuously recycled from unjust historical eras, is the driving force that will continue and contribute to building a new foundation rooted in equity for all populations. We look forward to seeing you all again next year. Until then, please take care and get some rest, as Dr. Nunes Smith advised us today. Thank you all.